This another interesting session of webinar on diagnostic errors in NICU, identification and management approaches. I'm very happy and it's a great pleasure to invite and have the presence of Dr. K. Suresh Gautham, who is from Professor of Pediatrics, Baylor College of Medicine and Neonatologist, Texas Children's Hospital. He is also a Deputy Editor, the Joint Commissioner General of Quality and Safety, Senior Editor of Neonatal Group of Cochrane Collaborative, Editor in charge of Diagnostic Test Accuracy. Dr. Suresh, it's a great pleasure to have you here, and we are excited, as so are our participants from across the country and maybe beyond the country for that matter. I will request Ashna to please introduce Dr. Suresh Gautham, his important accolades and your achievements across the field of neonatology. Dr. Ashna, please.
Thank you so much, sir. As rightly mentioned, Dr. K. Suresh Gautham is Professor of Pediatrics at Baylor College of Medicine and Neonatologist at the Texas Children's Hospital. He is also the editor of textbooks such as Assisted Ventilation of the Neonate, Clinical Guidelines in Neonatology, and the Neonatology section in Rudolph Textbook of Pediatrics. There is also an editorial board member of the Journal of Perinatology, has also worked with the Vermont-Oxford Network for many years as a faculty member of the Vermont-Oxford Network's Quality Improvement Collaborative, the NICU project and the NICQ project, and as an advisory board member for the NICQ. Sir also set up and directed several educational courses on patient safety, on evidence-based medicine, and on communication in healthcare. Sir also chairs the American Academy of Pediatrics program, Education and Quality Improvement for Pediatric Practice for 13 years, and is now a member of the group managing this program. He is a graduate of the master's program of the Dartmouth Institute of Health Policy and Clinical Practice, where his concentration was continuous quality improvement in healthcare. His interests include patient safety, quality improvement, evidence-based practice, ethics, leadership, and physician resilience and burnout. He's a popular speaker and teacher. He has given numerous invited lectures and workshops on these topics. It's a privilege to have you here, sir, and the screen is all yours. Thank you so much.
Thank you, Ashna, and welcome again, Dr. Suresh, and the participants, and we all are waiting eagerly for your sharing of experience. Please.
Good evening, everybody. Can you hear me?
Yes, sir.
Yes, sir.
Can you confirm that you can see my slide?
Yes, sir.
Yes.
And is it moving?
Yes, sir.
Yes, sir.
Okay. I want to thank the organizers for inviting me to give this talk, and I'm really looking forward to engaging with the audience and teaching and learning from them. Although the brochure said I'm going to be talking about diagnostic errors in the NICU, my talk is really broad and applies to all branches of healthcare, not just NICU. I don't have any financial interests to disclose, and I don't have any conflicts of interest. And I want to start by acknowledging my teachers and professors and mentors through my career, from whom I have learned so much, including a strong foundation of good clinical skills, which I picked up in my medical college in Karnataka. I want to start by asking the audience members to read this X-ray. What do you see in this X-ray? Either chat in your comments or talk. Anything?
Sure. If anyone wants to talk, you can just click on the raise hand button and we'll unmute you so that you can speak. Anyone who wants to speak can just click on the raise hand button. Okay, we have Shalu Gupta.
Okay, somebody said it's a pneumothorax, very good. Any other answers or any other observations?
Bilateral tubes in both the pleural spaces with right-sided pneumothorax.
Very good, yeah. So I was part of a team of doctors and nurses and nurse practitioners taking care of this baby. It was a preterm infant with pneumothorax, bilateral. We put in chest tubes. Eventually the baby got better. And before the baby improved, we actually had to put in a third chest tube because the pneumothorax was so difficult to treat. But did anybody notice a fracture of the left humerus in this baby over here. Do you see it there? Can you see my arrow, my pointer on the screen?
Yes, Dr. Gautham,
Yes.
it's visible. Yeah.
Yeah, so all of us, including me, completely missed this fracture of the humerus. And it's there on the follow-up x-rays as well. So we discovered that fracture after several weeks when there was a callus. And then we went back and looked, and we found that there always had been a fracture, but we were focusing so much on the pneumothorax that we missed this finding. So this is an example of a diagnostic error where there's a condition in the patient, but the clinicians don't pick it up. So how often do these occur? How bad are they? And what is the importance of them? That is what we will be talking about in today's talk. The definition of a diagnostic error, which has been described by the National Academy of Medicine in the United States, is the failure to establish an accurate and timely explanation for the patient's health problems and communicate that explanation to the patient. So please note that this definition not only includes the description of the problem, but also the failure to communicate to the patient, because that is the final step in diagnosis. How often do these occur? In 1999, the Institute of Medicine published a report called Air is Human. And that really kickstarted the patient safety movement and created a focus on medical errors in the healthcare system. But if you look just at diagnostic errors, which were ignored in the initial first 15 years of the patient safety movement, it is estimated that 40 to 80,000 deaths occur every year in US hospitals in patients of all age groups, not just pediatrics, from misdiagnosis. If you look at autopsies, 5% reveal lethal but preventive diagnostic error. And if you look at the tort claims, which are medical legal lawsuits for diagnostic error, they are twice as common as medication errors, and they lead to the largest payouts in cases where the doctors lose the cases. So this is really important because it is hurting patients and it is hurting doctors and health systems. It's so important that in 2015, the National Academy of Medicine published a report similar to the original report on medical errors called Improving Diagnosis in Healthcare. And this really pushed our field to do a lot more research and discussion about diagnostic errors. How common are diagnostic errors in pediatrics? In one paper, 28% of children with new oncologic diagnoses were found to have a diagnostic error. In children with osteomyelitis, 38% had a missed or a delayed diagnosis. Similarly, 54% of patients with a high blood pressure, 11% of patients with abnormal lab values, and so on. So these are quite common in pediatrics. Of course, we don't have studies from the Indian setting, so it would be nice to get some data from at least hospitals in the Indian setting to see how frequent diagnostic errors are. So these are other data on the frequency of diagnostic errors in pediatrics. I'm not going to read every number, but suffice it to say that diagnostic errors are a problem in healthcare in general, but also in pediatrics and in the NICU. And the scary thing is, if you or I become a patient and we go to the hospital or to the doctor, we are likely to suffer from a diagnostic error as well if we become patients. So we have to be on alert even as patients. So we did a study, one of our fellows, Grant Schaefer, worked with me to come up with a method of identifying and measuring the frequency of diagnostic errors in the NICU. We developed an instrument called the SAFER DX NICU instrument. The objective was to determine the frequency of diagnostic errors in the NICU using the SAFER DX instrument. We reviewed 600 consecutive inborn patient charts, evaluating the first 7 days of admission, and applied the SAFER DX instrument to every single chart. This was a 12-question algorithm to identify the presence or absence of diagnostic error. And these are our results. I won't go through the entire flow sheet, but by reviewing 600 charts, we ultimately found 37 diagnostic errors. So the frequency was 0.9 errors per 100 patient days. And remember, these are only the first 7 days of NICU admission. So this is the first study from the neonatal intensive care unit showing a high frequency of diagnostic errors in our field. We also described the types of errors seen and classified them as missed or misinterpreted maternal history findings, incomplete or incorrect physical examination. For example, we had a baby with an imperforate anus that was sent to the normal newborn nursery and was discovered later to have an imperforate anus. We had a baby who had corneal opacification, but somehow that was missed and was picked up after 3 or 4 days after the baby was in the NICU for some time. So misinterpreted or missed lab study results, imaging studies, just like the one I showed you with the fracture that was missed by us, and missing of equipment malfunction. That was also part of the type of errors that we found. So in summary, 6.2% of the patients in our study had diagnostic errors with a frequency of 0.9 per 100 days, 100 patient days. And we developed a methodology of reviewing charts for diagnostic errors. And this is a methodology that has been used in multiple specialties. And if anybody in India wants to do a study of this nature, please contact me and we can work together to do a similar study. So why do diagnostic errors occur? Now, this is the more interesting part, and it's applicable to healthcare and medicine in general, not just to neonatology. So let's go into the theory and the principles of diagnosis and where things can go wrong. To understand why diagnostic errors occur, you have to go back to your medical school days or nursing school days and understand that diagnosis starts with good information gathering, which starts with a good history, physical examination, lab tests, imaging, and other tests. And of these, I highlighted physical exam with a different color because I think in medicine across the world, we're all losing the skill of good physical exam. I remember when I was a medical student in the mid 80s and a resident at PGI, there was a huge emphasis on learning how to examine a patient well. And of course, a lot of that was driven by the fact that we would be tested for it in the exam, both for medical college and for your MD Pediatrics and DM. But in general, this is a dying skill and we need to preserve it. So once you gather the information, we go through a process of integrating and interpreting the information, which requires knowledge of the subject and good methods of cognitively processing what information you have. Then you come up with a working diagnosis. You communicate the diagnosis to the patient, family, and to the team members. You initiate a treatment, look at the outcomes, and then you may realize that what you had was just a provisional diagnosis. And sometimes you have to go back and gather more information and refine your diagnosis or change it completely based on other facts that emerge during the course of the patient's care. So this is what happens, and breakdowns can occur at any stage of this. Authors from Iran, Yazdani and Aberde, have published this nice model called the cognitive zipper model, where they hypothesize that clinicians are simultaneously doing two things. Just like a zipper closes as you zip it out. On the one hand, you're taking the information from the patient and creating a representation of the patient's problem in your mind, which is a cognitive model. And simultaneously, you're applying reasoning and cognitive processing to that model you've created. So together, the cognitive model and its representation and the reasoning and the critical thinking that you're applying together will lead you to the diagnosis. And if you don't do both of these well, then, or if you don't do either of these well, then you can go wrong and miss the diagnosis. So where can we go wrong with information gathering? Poor history taking is common. And especially in our field, now we have electronic medical records. So people just import data from the mother's chart into the baby's record. And they have forgotten how to talk to families and gather a good history from the families. Inadequate physical exam, I've already elaborated on that. There is an author from Texas who has used the term hyposcilia to describe the decreasing skills of physical exam and the atrophy of good physical exam skills in medicine. I think all over the world, indiscriminate lab testing and over-reliance on test results, frankly, much of it driven by profit, has taken over medicine. And medical records in many cases have missing information, it's incomplete or inaccurate, especially when patients come to us from a village or from another town, or they're transferred from one hospital to another. You might not get the complete story of what happened before admission. And then during the COVID era, we are shifting to telemedicine, and God knows what new types of diagnostic errors will be created because of our over-reliance on telemedicine in the COVID era. I'm sure there will be new patterns of errors that emerge due to telemedicine. So I want to give you an example of how information is organized and laid out can help or hinder diagnosis. So this is the CSF results of a baby in a NICU that I was taking care of once when I was covering on a weekend. So what do you think of this CSF result? Does this baby have meningitis or no? Anybody? You can chat in your response or you can speak. There's no penalty if you get the answer wrong, so don't be afraid. Just share your observations. So Rajiv is saying yes, there is meningitis. Abnish is saying no. Yes. Okay. Syed is saying baby has meningitis. Anyway, this was a real case. I was rounding on a weekend, cross-covering a colleague. And this was a baby that they had started treatment for meningitis. They had put in a central line to give antibiotics for a long time. And they were going off this cell here where it says CSF NQOCN 8. And based on that, they felt the baby has meningitis. But it turns out that what the lab was trying to tell us by using CSF NQOCN was we counted 8 nucleated cells to figure out the differential of the count. And based on that, I'm sorry, look at the bottom row. Look at the bottom row, CSF, CEL, CTD. That's what I was referring to. It says 156. So the clinical team looked at that number 156 and said, this baby has meningitis because there are 156 cells per cubic millimeter. And what the lab was actually saying was, we looked at 156 cells to come up with the differential count on the CSF WBCs. So this was an error that was fostered by the electronic medical record and how information was displayed. So how information is displayed in the chart is also very important. That's the point here. Here's another example where a baby was wrongly diagnosed to have thrombocytopenia because the resident started off reading the platelet count by looking at this row called PLT. And as they were reading across, they crossed a line and read 34, which means they thought the platelet count was 34,000 and transfused the baby with platelets that night. And if this computer interface had alternate shading of the lines, so the light shade and dark shade would help you track across the row horizontally accurately, then that error could have been avoided. Again, another example of how computers can mislead you. So that's where one category where breakdowns can occur, which is information gathering and information presentation. The other area is called agnotology. Agnotology is the science of ignorance. And there are courses you can take on this and philosophical textbooks you can read about this. In 2002, Donald Rumsfeld, who recently died, said during a press briefing, he was talking about the Iraq war and the weapons of mass destruction there. He said there are known knowns. There are things we know we know. We also know there are known unknowns. That is to say, we know there are some things we do not know. But there are also unknown unknowns, the ones we don't know. So if the clinician or the resident or the medical student doesn't have the knowledge in their mind to recognize what they're saying, that can also lead to diagnostic errors. For example, if you or I hear an adult patient complaining, I hear my eyes move, we might think that this patient has a psychiatric problem because how can you hear your eyes move? But it turns out there is a condition called superior canal dehiscence syndrome, where the movement of the eyeball can cause sounds within your skull, and the patient is hearing sounds when the eyes move. So if I don't know about superior canal dehiscence syndrome, I will never recognize this symptom. Similarly, we had a baby with perinatal depression and encephalopathy with intractable acidosis, did not get better no matter what we tried, and ultimately turned out to have Barth syndrome, P-A-R-T-H, which I had not heard of until I had encountered that baby. So agnotology and not knowing the subject also is an important contributor to diagnostic errors. So next, let's talk about cognitive processing. And I will show you some photographs and I want you to quickly respond with the diagnosis, either in the chat or by speaking up. Okay, what does this patient have?
Down syndrome.
Very good. What does this patient have?
Congenital hypothyroidism.
Very good. What does this patient have? Okay, nobody is going to get this answer because this is something called Okamoto syndrome, and there are only 6 or 8 cases reported in history in medicine. Okay, so but let's look at what happened. When I showed this picture, somebody within half a second said Down syndrome, right? When I showed this picture, there was a pause, but after a few seconds, somebody said congenital hypothyroidism. And for this, there was complete silence. So that means in some cases, we can look at a patient and without thinking immediately say, okay, that's what this is. And that's what great clinicians do sometimes. Sometimes we need more time to process and say, okay, this baby has a coarse facies, protruding tongue, umbilical hernia, so probably congenital hypothyroidism. So you're like slowing down your thinking and analyzing what you're saying. And here you're trying your best to analyze, but you can't get it because it's not in your database, the Okamoto syndrome. Daniel Kahneman and other colleagues a few years ago published a book called Thinking Fast and Slow. And that has led to this dual process model of reasoning. And this is the type of thinking we apply in life in general, whether you're deciding to buy stocks or choosing whom to marry or making a diagnosis in a patient. Every type of thinking we do can be categorized into system 1 and system 2 thinking. So system 1 is an intuitive, fast, pattern recognition type of thinking. And system 2 is slower, it's methodical, it's analytical, and it is much slower. It's rule-based thinking, where you systematically work through a process. So system 1 is the intuitive one, and it's very efficient and quick, but it's also likely to mislead you because it is prone to biases. System 2 is methodical and analytical, and you're less likely to miss some important points and not overlook them, but it is slower, and we just cannot afford to do system 2 thinking in every patient if you have a busy OPD, or if you have 30 patients to round on. You can't do system 2 all the time. System 1 is what gets us through the day in an efficient manner, but it can mislead you. So knowing these two patterns and being aware of what pattern you're using to diagnose a patient is very, very important. Malcolm Gladwell wrote a book several years ago called Blink, and he talked about how experts in different fields can look at something and immediately within a second, within the blink of an eye, identify that this painting is fake or this sculpture is not the original Michelangelo, or this is a certain pattern of bird. But in response to that, Michael Legault proposed that we should teach people how to think and not glamorize instantaneous and heuristic-based system 1 thinking. Both are important. And this is illustrated by these two characters from Star Trek. I don't know how many of you follow this, but Captain Kirk.
Captain Spock.
Can you all mute your microphones, please? So Captain Kirk is very impulsive. He's dashing. He doesn't think. He doesn't slow down. He makes instantaneous decisions. And Lieutenant Spock is always analytical, slow, methodical, weighs all sides of an equation before making a decision. So both are important. You can't say one is superior to the other. So when we talk about system 1 thinking and how it is intuitive or fast, it is based on a concept called heuristics. Heuristics are shortcuts in reasoning and subconscious rules of thumb used to solve diagnostic puzzles. For example, we all get taught very early in our medical school days, if a middle-aged man comes to the emergency room or casualty with chest pain that is radiating down the left arm, that's myocardial infarction unless otherwise proved. That's a heuristic. So similarly, we have many heuristics. If you have a 6-week-old baby with projectile vomiting, instantly your mind will say that is congenital hypertrophic pyloric stenosis. So we all have heuristics, either explicit or implicit in our mind. And these are efficient mental strategies with which to deal in an uncertain and ambiguous world. They occasionally fail, even though they help us very often in speeding up our work. They're not intrinsically bad, but we just have to train ourselves to recognize that this is what is happening in our mind, and we could be going wrong, or we could be on the right track. So this ability to observe your thinking and be aware of your thinking is called metacognition. So there is a large body of literature on heuristics and the cognitive process that lead to error. We don't have time to get into it. I'm putting the references down at the bottom of the slide. One common heuristic is the availability heuristic, which is a tendency to judge diagnoses as more likely if they're more easily retrievable from memory. So if you've seen a recent patient with some condition, or you're working in a ward that has a lot of those patients, then you're likely to think, like today, if you go into any hospital and any patients presenting with any respiratory symptoms or fever, everybody will think of COVID-19 as the number one possibility, right? That's the availability heuristic. Because COVID is all around us, we're talking about it constantly, it's in the news. So that's a classic example of availability heuristic. Confirmation bias is a tendency to seek data to confirm, not refute the hypothesis. So if I say this patient has tuberculosis, and I'm going to be very reluctant to accept information that points against tuberculosis. So that's confirmation bias. Premature closure is a tendency to stop too soon and say, okay, I have found the culprit and I'm not going to look anymore or think anymore about what else this patient might have. Similarly, there are other heuristics called base rate neglect, representativeness heuristic, framing effect, and so on. For example, if I tell you this patient has a 40% chance of survival, you will view that patient's situation much more favorably than if I were to tell you this patient has a 60% chance of mortality. And whether you use the word survival or mortality will influence how you view the condition of the patient. That is known as the framing effect, even though numerically I'm presenting the same information to you. Clinicians also have a lot of overconfidence in themselves. So when I make a diagnosis, I'm pretty confident that I'm right. And I may not be aware of my tendency to go wrong with diagnosis. So learning some diagnostic humility is important if you want to be a good clinician. And these are the other types of cognitive biases that have been described in the literature by psychologists and cognitive experts. We don't have time to go into these, but suffice it to say, how your mind processes information and arrives at diagnosis can be very treacherous. So we have to watch out and use metacognition. So here's another interactive exercise for you. What do you see in this image, in this photograph? Anybody?
Look like mountains with some rainfall, busy picture. Water coming down mountains and all waterfalls and some valley.
Very good, thank you. Anybody else? Snowstorm, horse, lady dog, cow face. Anyway, when I saw this for the first time, I just saw like black and white patterns. I really didn't see anything, but I'll do something and then I'll come back to this, and I want you to observe how your perception of this image changes after I show you the next slide. You ready? Wait, there's one more chat. Let me see what they say. Snowfall at mountain. Okay. So, what do you see now?
Yeah, it's a cow face. Yeah.
Sudhir, what do you see now?
Cow face.
Cow.
Sudhir previously saw snowfall at a mountain, but now he's seeing a cow face. Right? Okay. Now I'll go back to the previous image that without the outline of the cow face, and tell me what you see. Do you see the cow face?
Yeah, yeah, we can make it out. Yeah.
So once you see this, and once you realize there's a cow face in it, if I show you this image, you can never look at it how you looked at it the first time you saw it, because there is a like a pre-formatted impression of this in your mind. And so it has forever changed how you look at this image. And this is a very powerful illustration of how human cognition works, that we can become conditioned to see things in a certain light. And that can either help us or it can be a trap that can mislead us. So this is an exercise that Dr. Pat Croskery, who's an expert in diagnostic errors, used in one of his talks, and I'm sort of just borrowing it from him. So let me stop here and see if there are any questions before I move on to how to prevent diagnostic errors.
So we'll request the participants to unmute themselves and ask questions if they have any queries.
Any questions so far?
We have one question in the Q&A box.
Yeah, Ashna, please go ahead.
Okay. So Dr. Praveen Venkatgiri is asking, what's the historical trend of errors in the last couple of decades? Are errors increasing or decreasing with concerns regarding hyposcalia and use of computers? Are patients at increased risk compared to the past, or are we recognizing our limitations better?
So we welcome Dr. Praveen Venkatgiri. Thank you, Praveen, for joining. He's one of our important board members of NQOCN. Dr. Praveen is from Bangalore, from Ogun Hospital. Yeah.
Yes, yeah, Praveen is a good friend of mine. So thank you for the question, Praveen. Unfortunately, we don't have data on the trends with errors in diagnosis. I think that's work that needs to be done. And I also cannot tell you confidently whether new modalities of use of electronic medical records, telemedicine, are making things worse or better. I think in some ways things might be better, but in other ways things might be getting worse. So unfortunately, we don't have data, and that is why we're doing a lot of research in this area to come up with some answers to your question. Thank you. Any other questions? I can't see the Q&A box, unfortunately. How do you reconcile the need for both
Yeah, another
analytic
interesting
and
question from
heuristic?
Dr. Saeed. He's also a great patron of our NQOCN. Dr. Saeed question, analyzing between heuristic and naturalistic, sir, please.
Yes, so that's a very important question. And I think as clinicians, we need to be aware that there are two types of thinking that we use. We also need to be aware of which type we're using at any given moment in time. And I'll talk a little bit about that in the prevention section. For example, if I'm called to an emergency in the ward and I go to the bedside and the patient is in shock, I will immediately form some conclusions and start some treatment. And I'll give you an example. I was doing rounds and there was a baby who suddenly collapsed, 26 weeks baby on CPAP, suddenly arrested. We went and intubated and did CPR, gave medications. The baby was not improving. So until then, I was just using heuristics based on my impression of the baby without thinking too much. But when we had done the airway breathing circulation and medications and the baby was not improving, I stepped back and said, okay, let me think through this in a type 2 analytical method. We've done this, we've done this. What else could be going on? I looked at the x-ray. The PICC line in that baby was very deep. So I told the nurse, give me a butterfly needle, and I put a needle just to the left of the xiphoid process, pointed it towards the left acromion, and aspirated, and I got TPN from the pericardial sac. And I was able to do that because I was using analytical thinking after the heuristic thinking failed me. So that's an example of how we should learn to balance both and not always be in one side or the other. So while there is a need, my concern is, are we even aware that we're doing this type of thinking? I would say no, most of us are just automatically, reflexly going through the day. So we need to slow down. Do we have the necessary headspace or awareness? And I, incidentally, am a big practitioner of meditation and mindfulness. And mindfulness allows you to observe what is happening in your mind. And I think that's a very good approach. Shalu Gupta is saying simplistic approach. I can't tell if she's agreeing with me or criticizing what I'm saying. But anyway, we can talk more about this.
Shalu is a pediatric intensivist, sir, from Lady Harding Medical College, and I hope he's agreeing with you. Yeah.
Yeah. But yeah, sometimes we take an oversimplified approach, and that is wrong. For example, if we come up with like protocols and say, if this and this, do a sepsis workup, but we might miss an inborn error of metabolism if we're not thinking through a situation and identifying some unusual patterns. So some introspection and awareness of your cognition is important. And we can talk more about this later. So let me go through this section on prevention of diagnostic errors. And I just want to caution you that the evidence for what I'm talking about is of low quality. There are no randomized trials to support the fact that using X or Y method will definitely reduce diagnostic errors. This is a very new area and a lot of research needs to be done in this area. I came up with a model many years ago related to patient safety called the WHO model. In the past, in patient safety, when there was a medical error of any kind, not just a diagnostic error, we used to blame people and punish them. And then the patient safety movement in the year 2000 emphasized the need to focus on systems of care and not on individuals as a method of preventing diagnostic or errors, as a method of preventing errors. So when an error occurs, we have to ask ourselves, what were the work conditions under which the nurse or the clinician was working? What were the human conditions and what were the organizational conditions? So work conditions are things like work schedules, equipment, workplace design, decision support, and so on, that either help or hinder the function of the humans. Human conditions are training, fatigue, stress, poor communication. These things can also affect how safety and errors occur or don't occur. And organizational conditions. What is the safety culture of an organization? Is it safe to speak up and point out hazards, or will you be punished? Is there good teamwork? Is there good leadership? And do leaders allocate enough resources to safety? All these things are responsible for safety or errors. So if you apply this thinking to the process of diagnosis that we went through earlier, we can see that the potential interventions can occur in many stages. We can ensure mechanisms to ensure that there's good information gathering. And we can ensure clinical training to improve our cognitive processes and communication and so on. And also, most importantly, this arrow that is looping back, we should also try to improve how we get feedback about a diagnosis that we made and learn from it constantly. So one of the earliest steps in that is information gathering and getting a good history, doing a good physical examination, and getting in the habit of generating a differential diagnosis. Very often our fellows and some of my colleagues will go directly from the presenting symptom to which tests to order. So there's a child presenting with seizures. Okay, order an MRI and an EEG and get a neurology consult. So there's no step of thinking why this patient is having seizures. Does the patient have encephalopathy or is he alert? So going through that differential diagnosis phase is very, very important. Good documentation in the chart is important, not just the content, but how you organize the information is important. Using diagnostic checklists can be useful. For example, if you have a patient with headache, if you have a checklist of questions to ask, you will not forget to ask about some important aspects of the history or the presentation that will clue you into the diagnosis. For example, if you have a patient with some obscure symptom, asking about the use of alternative or naturopathic medicines is important, because that might give you a clue where the rest of the history you're drawing a blank. Using consultation appropriately and not overdoing consultations with cardiologists and neurologists and so on is important. And then there's this concept of team member cross-checks. So if I'm doing rounds and if I examine a patient and I say, okay, I think this patient has X, then one of the other members on the team should have the habit of questioning me and saying, okay, that's the most likely diagnosis, but what could we be missing in this situation? A great example is one of my colleagues was doing rounds, and there was a patient with persistent respiratory problems where they had difficulty extubating the baby. and they were considering doing a tracheostomy. And one of the colleagues asked this question, what else could be going on? Are we missing something? So that led to them examining the x-rays going back a few days. And they found that the baby had a persistently elevated right hemidiaphragm. And that patient actually had right diaphragmatic paralysis following a repair of an esophageal atresia. And nobody until that point, including the radiologist, had made the diagnosis. But by stepping back and asking, could we be missing something? What else could this be? It led to a re-looking at that clinical scenario, just like we looked at that cow face, and they found the diagnosis. So cross-checking other people's assumptions is very important, instead of just assuming that whatever the other people said is the complete truth. So metacognitive training and reflective practice is important, especially when we do case discussions and when we do our PG teaching. It's very important to train people in critical thinking and metacognition about their own thinking. Mindfulness, I've mentioned, is an important and useful method that will help you be aware of your own cognitive processes. Diagnostic timeouts are important, and they can help. For example, if I admit a patient and say, okay, this is RDS, I can force myself to do a diagnostic timeout and say, okay, this looks like RDS and it's behaving like RDS, but could it be something else? And I'm doing this by myself. And 20 years ago, I had a patient who presented exactly like RDS, but turned out to have total anomalous pulmonary venous drainage, a 28-weeker. So I can force myself to think and say, okay, this is RDS, but could it be TAPVR? Let's think about that. That's called a diagnostic timeout. Cognitive forcing strategies are similar, and they're known as debiasing. And I can tell myself, okay, you have committed to a diagnosis of meconium aspiration syndrome in this patient, but could you be subject to confirmation bias, and are you ignoring the fact that X, Y, and Z exist in this patient, and therefore you need to get an echo to look for congenital heart disease? Then another technique is called prospective hindsight technique, where you you kind of come up with a scenario and you tell yourself, okay, you're treating this patient for, say, volvulus. Let's imagine that this patient actually has some other diagnosis and you're missing that diagnosis. What will happen if you go in and do surgery and later on you find out that the diagnosis was something else? So that's called a prospective hindsight technique. Follow-up is very, very important. So when you admit a patient or when you manage a patient in the clinic, you should always get in the habit of following up and seeing what happens to the patient later on. And that will tell you whether you missed a diagnosis or you made the correct diagnosis. And always being willing to do diagnostic revision, because any diagnosis you make is a provisional diagnosis, and none of it is final until you're 100% sure of the diagnosis. So this is a cartoon where the doctor's saying, this is a second opinion. At first, I thought you had something else. So not all doctors are willing to revise their opinions about their own diagnosis. Anyway, so I mentioned the lack of evidence. There is a systematic review of strategies to reduce diagnostic errors that included 26 studies. And the interventions that they listed in that systematic review are shown in this slide, but their bottom line conclusion was that there is limited evidence of efficacy. So all these things have to be taken with a pinch of salt. So what is the greatest diagnostic error ever made in the US, at least? And the answer is the failure to introduce COVID testing in a timely manner by the CDC in the country in December 2019, when COVID first appeared on the scene. And the failures in testing and not allowing other labs to perform the tests led to the epidemic getting a foothold and spreading rapidly without the ability to identify, quarantine, do contact tracing, and isolate patients. So to me, that represents the greatest diagnostic error. Okay, so last few slides. What do you see in this slide? Okay, let's keep going. What do you see in this one? I'm sure many of you might have seen this visual. So let me wrap up the talk and let me give you the answers so that we have time for discussion. This is a well-known image where you can look at it and either see an elderly woman with this being the nose of the woman, and this is the mouth, and this is the hair. Or you can see a young woman who is looking away from you and you're looking at her from her left side with this being the eyelash, this being her nose, and this being her chin. So again, it illustrates the importance of recognizing how your cognition and perception can mislead you. And sometimes what you're looking at is not what is really there. Or there may be more than one way to look at things. Okay, look at this text and tell me how many times does the letter F appear in this sentence? F as in father. So I'll give you the answer when this is given to people. Many of them will count the F's that are at the beginning of the letters like functional fuses, but they will miss F's that are in the middle of the word, like in the F in scientific. So they always get the number wrong. And because the way we read, we don't pay attention to every single letter of every word. We just get impressions of words and texts, and we form meaning from that. So that's what this exercise reveals. And again, this is a visual that shows how our pre-exposures can bias us into seeing one thing. For example, if you start with the figure of a man who looks a little grumpy, and you change the figure a little bit, you see a sitting woman. But if you don't show that, then the figure appears very different. So the same figure can look very different at the end based on which figure you start looking at first. So in conclusion, diagnostic errors are common and serious. Cognitive biases underlie many such errors. Critical thinking and cognitive debiasing strategies may reduce diagnostic errors, and much more research is required before firm preventive recommendations can be made. So